Aloha and welcome, everyone. Thank you for joining us for today's session on cancer disparities and survival in Hawaii. My name is Brenda Hernandez. I'm a researcher at the UH Cancer Center, and I'll be moderating today's panel, which will include four of my wonderful colleagues. To start off, I'll provide a brief overview of the burden of cancer in Hawaii. Annually, we see approximately 7,400 Hawaii residents who are diagnosed with cancer, and over 2,300 Hawaii residents die of this disease each year. Cancer is the second leading cause of death in the state, next to heart disease. Currently, there are an estimated 67,000 Hawaii residents who are cancer survivors, having been diagnosed with cancer in the past or recently. So these are the top cancers, the most frequently diagnosed cancers in the state. Among men, prostate cancer by far is the most commonly diagnosed cancer, comprising about 22% of all newly diagnosed cases. And among women, breast cancer by far is the most common cancer among women, comprising over a third of all female cancers. And among both men and women, lung and colorectal cancers are also among the top cancers diagnosed. And listed here are other top cancers that are the most frequently diagnosed cancers in the state. And they're largely reflect what we also see nationally in the United States.
Thank you, Dr. Hernandez, for the introduction. I am Lani Park. I am a cancer epidemiologist at the University of Hawai Cancer Center. And I'll be talking briefly about racial ethnic risk factors. Clearly, I can't cover everything in the given amount of time, so please feel free to put your chat and your Q&A questions, and then we'll be able to answer them. Okay, so Dr. Hernandez showed a list of the top cancers, and this is sort of showing a snapshot of the 5 leading cancer sites by sex and by race ethnicity in Hawaii. These are the common racial ethnic groups: Native Hawaiian, whites, Chinese, Filipinos, and Japanese Americans. And as you can see, as Dr. Hernandez has mentioned, that prostate cancer is the most common in men, and then breast cancer is the most common in women, so red being the most common cancer. But if we go to the second most common cancer, which is in green, and then the third most common cancer, which is in yellow, the ordering does change across the racial ethnic groups, and this is observed in both the men and in women. For instance, with Native Hawaiians, the second most common cancer is lung cancer, and the third most common being colorectal in Native Hawaiian men. And then among white men, the second most common is melanoma, and the third most common being lung cancer. And then women, we use the same groups as examples. So Native Hawaiian women, it's breast is first, and then the second is lung, and third being endometrial cancer. Whereas in whites, the second is lung, but the third is melanoma. And what contributes to these differences in the incidence of cancers across these populations, in part, is due to the risk factors that may differ across these populations. So some of the common risk factors for many of cancers is age, and that depends on the type of cancer, as well as the family history of cancer, tobacco, and then diet, obesity, physical inactivity, reproductive factors, alcohol, chemical exposures, some infectious diseases such as the human papillomavirus and hepatitis, and exposure to radiation. This includes ionizing radiation such as solar radiation, as UV, and then ionizing radiation. An example of that would be sort of like nuclear exposures. So I'm going to provide 2 examples, one being cervical cancer. And the reason why I'd like to use cervical cancer as an example is that it's one of the most amenable cancers in terms of prevention. So we know that the risk factor is human papillomavirus, as well as smoking, because there is an interaction between the 2 risk factors. And then the preventive factors is early detection through regular screening from pap smears, as well as prevention. And then there is the HPV vaccine, which is required in the state of Hawaii recently, and this is shepherded really by the work from Dr. Hernandez. You can see that even with all this effort back in 2000 to 2005, there clearly is still cervical cancers still occurring in the state of Hawaii, and it does differ across the racial ethnic groups. With a lot of effort to increase prevention as well as vaccination, these rates have changed over time, but it's clear that there are still persistent disparities across the populations that need to be addressed. Another example is lung cancer, where here, this is just looking at the age-adjusted rate of cancer that occurs in Hawaii, and I'm only using males as a snapshot, but this is a similar pattern is present in females. And you can see that Native Hawaiians and Filipinos do have a higher incidence of lung cancer. And it initially was speculated that this may in part be due to the higher rates of smoking in some of these populations. And while that may be contributing to the higher incidence of lung cancer, what we did find at the University of Hawaii Cancer Center is that even when you control for the amount of smoking, that there are racial ethnic differences that persist. So if this brown color is supposed to be Native Hawaiians, and then the blue is African Americans, compared to whites, which is in this lighter blue, they do have a higher risk of lung cancer, even when controlling for this history of smoking, which is the primary risk factor. So again, a lot of these differences come in part to the different exposure, but in part also due to variations in genetics, which Dr. Le Marchand will be talking about shortly.
Hello, my name is Eric Le Marchand. I'm an epidemiologist at the Cancer Center as well. And I work on also trying to understand ethnic differences in risk, looking often at the interaction between genetics and lifestyle. So what I was asked to cover today was the relative importance of genetics and lifestyle in the causation of cancer. So cancer is a somewhat often referred to as a genetic disease, but really what is meant there is that it is due to certain genes being changed or mutated during life, and those genes often have a role in cell function, such as related to growth or divisions. So those are acquired changes in our gene. So that needs to be distinguished from genetic susceptibility, which are differences in our genes that are inherited from our parents and grandparents. So in terms of those inherited cancer genes, it is good to differentiate those that are rare, but are associated with a very high, moderately high risk of cancer. So if you inherit those genes from your parents, you are more likely to develop cancer, or usually a specific cancer related to a specific mutation and a gene. And just to take the example of BRCA1, one of the major cancer gene for breast cancer, your risk can be increased between 30 and 60% if you have these genes, depending on the mutation you have and other risk factors, actually. So and I'm talking in terms of lifetime risk. So if you are 20, you have about a risk varying between 30 and 60% over your lifetime to develop breast cancer if you have this gene. And that needs to be distinguished from other susceptibility genes, which are just variation in our DNA that just happen to be in important genes, but that can be quite common. And when I say common, it could be up to 80, 85, 90% of the population sometimes. But those are associated with a very small increase in risk. So very different concept. If you have a family, major cancer genes that are usually inherited in cancer families, it's very important to get tested, because knowing it will help your physician prescribe a screening schedule that would be related to your risk. So if you don't have the gene, you can be screened like anybody else in the population. But if you do have the gene, then you need to be screened at an earlier age and more often than the rest of the population. Relative importance of genetics in cancer. Well, if you have a family history of cancer in general, that increases your risk by 2 or 2.5 fold. So it's important to know your family history. And often people don't know because it's not thought about so much in our families, but it is a good question to ask or to pay attention if you hear that, your grandfather or your parents or your brothers and sisters have a specific type of cancer, your risk then is increased by about 2.5 fold for that cancer. But as you know, there are cancer families where there are multiple cases of cancer, usually some cancer, but sometimes it can be groups of cancers, actually. And we refer to that as hereditary cancer syndrome. And those represent about 5 to 15% of all cancers. So major cancer genes such as BRCA1, across all cancers represent about 10 to 15%. And the rest are unrelated to genetics, or really slightly related to genetics possibly, but represent much greater contribution. It's also known that if you are a twin and if your twin develop cancer, you are then at greater risk of developing cancer yourself. It's an increase of 37% for a non-identical twin and up to almost 50% for an identical twin. So it's also a good thing to know. So what studies are really shown that
Hello, everybody. Thanks for being here today. So my name is Erin Bantum. I'm a clinical health psychologist, and I work in the area of cancer survivorship. But today I'm going to talk about behavioral factors related to cancer survival. So just to set the stage and the context a little bit, a few things that are important in my line of work are the cancer survivorship continuum. So research can be done anywhere along this continuum from diagnosis through the end of life in terms of a person being called a cancer survivor all the way along that line, in addition to certain aspects being more relevant at different times. In fact, most of my work happens at the post-primary treatment time point. And so I'm going to talk a little bit about some of my work as well today, but mostly just want to contextualize this. Something else that really started this field is originally looking at the impacts of the biological or physical impact on a body, how that impacts other areas of functioning. So in the field of cancer survivorship, we like to follow the biopsychosocial model, where there's the idea that there's many components of our lives that are important. And while they all take up their own space, they also overlap. So anything we do to a person physically is going to impact other areas of life. So the idea is really looking more at the whole person in addition to medically, in addition to these other areas. So I wanted to describe a little bit about how this can look in the way of some work. So some of the work that we've been doing looks at things like online health behavior change. So groups of survivors getting together and trying to identify behaviors that they'd like to change. Some can be biobehavioral studies looking at what happens both physically and psychologically when we engage in physical activity. We have some open studies now looking at mindfulness meditation. So how does mindfulness meditation impact anxiety as well as cancer-related neuropathy for cancer survivors? And we have a new study that we just started, which is actually with pediatric cancer patients receiving treatment and physical activity in support of other pediatric cancer patients. So just to give you an idea of what I'm doing and how that feeds in here, for today's talk, I wanted to look a little bit at behavioral factors that are related to survival. And so I spent some time in the literature and looked at a number of different meta-analyses to see what we could find here. And when looking at depression and cancer mortality, this particular study is a little bit older, so it was finished in 2010, but there were 76 studies included. So these researchers took findings from 76 different studies and put them together to see what could they find about this overall question of the relationship between being depressed and cancer mortality. And it was found that there was, in fact, a relationship. I believe it was about a 19% increase in relative risk. So other things carry a much higher risk, of course, but this is still significant nonetheless, and included cancer patients with many different types of cancer. So a few things that I took away from this, which were interesting, is that there's a particular inventory called the Beck Depression Inventory. And is what we know about depression is there's many symptoms of being depressed outside of having cancer that are physical symptoms. And so that particular inventory isn't what we'd call sort of valid on a cancer population in the same way that other measures might take some of those physical factors into consideration. And now I want to talk a little bit about physical activity and breast cancer survival. So for this meta-analysis, there were 43 studies looked at, and the highest recreational physical activity was associated with lower mortality related both to breast cancer as well as other causes. And here the relative risk, so whether a person passed away due directly to breast cancer or to other conditions as well. So there was a really strong relationship here in these 43 studies. And next, this has probably been the most controversial in the literature, the concept of stress and how that's related to cellular aging in cancer. So in this meta-analysis, which is really taking multiple studies again and bringing them together to look at any takeaway messages, which of course can be more powerful than looking at a study individually, although sometimes there's not as specific of information on the study. So it's helpful to dig into them a little bit more as well. But for this review, there were 35 studies included, again, with many, many different types of cancer. And there was also an association found with more recent increase in stressful life events. So in this case, these were stressful events. They could be related to cancer, but they also could be related to other very stressful events, such as, the grief of loss over a recent loss of a loved one, or other events in life outside of cancer. But what came about here in this study is that it's still hard to identify necessarily those mechanisms. So we're seeing that there's this relationship, but it's hard to sometimes identify the mechanisms between the stress and the risk. So that's where that was. And then I wanted to describe a little bit more. So that question, those findings that I just reported were really conducted from epidemiological research, and is what my work focuses on. And we don't often have the time to know directly about survival, because oftentimes that would take following patients for many, many years over time. And there's definitely a need for more of that in cancer survivorship. But is what we try and do in some of our studies is look at those markers that are related to survival. And so I want to describe a study that's done just that. And first, to acknowledge the team of researchers in the Kumahula and co-investigators, as well as some funding to run these studies. And there's been 2 studies conducted so far. So we have implemented 6 months of hula. So it's very long in terms of a physical activity intervention, but 6 months of hula where participants came in twice a week, in addition to being asked to practice 1 hour a week at home. And that was to fit those recommended guidelines. I'm going to talk just briefly about the first study today, which was one where we enrolled 11 people. But I did want to let you know in both studies, attendance was collected at each class, and heart rate was collected 3 times per class, in addition to anthropometric measures and blood demographics. So questions about who they are, their cancer, and other aspects like that. Self-reported measures of quality of life. We looked at mood, fatigue, depression, and social constraints, all reported via what we call self-report. So someone reads a question and identifies the option that fits for them best. And data was collected at 3 time points, so baseline, 6 months, and 12 months.
Everyone, and thanks for having us this year's Hawaii Book Festival. So my name is Sung-shim Lani Park, and I'm a pediatric clinical psychologist here at the University of Hawai Cancer Center.
Excuse me, Dr. Lim, could you speak a little louder?
Yeah. Is it better now?
Thank you.
How about that? Is it better?
Thank you.
All right. So my name is Sung-shim Lani, and I am a pediatric hematologist oncologist at the University of Hawai Cancer Center here, as well as a population center. So just a little bit about myself. So I'm originally from Hong Kong, and I came to the States for college, and really have stayed here since then. So I completed both of my residency and fellowship training back in Philadelphia, where I had a special focus on immunotherapy. And while I was there in Philadelphia, that's where I met my husband, who was a local girl that was born, raised, and Hawaii. And so that's how we did that 2 years. So I'm definitely thankful to have the opportunity to with all of the colleagues here at the Cancer Center and the chance to just contribute positively. So I think what Dr. Hernandez and I will do now is just do a little bit of an informal Q&A session and just chat about immunotherapy and gene therapy, and I'll show a few slides. So the floor is yours.
So maybe you could, we haven't discussed pediatric cancers. I mean, pediatric cancers are very rare. We know that we probably see about no more than 60 cases a year on average. But, a diagnosis of cancer in a child is a devastating event for a family. Maybe you could just touch on, some of the major pediatric cancers that are diagnosed in kids in Hawaii.
Yeah, that's perfect. So in the past 5 years, on average, you're absolutely right. We have had about 50 to 55 new cases every year. And I would say about 25 to 30% of them are acute lymphoblastic leukemia. The second one would be Hodgkin's lymphoma, and really the rest could be spread through the bone tumors, liver tumors, soft tissue tumors, etc. And I think Dr. Michelle actually brings up a really good point, because we spoke earlier about hereditary cancers. And actually that's super prevalent in our pediatric cancer population, because cancer in any children, honestly, is not rare. And so there's a huge genetic component of it that we always think about, especially in patients with, let's say, other abnormalities of whatever forms, and we think about symptoms that could be potentially related to the particular cancers. I think one of the best examples that I can really think of is actually bone cancers. And so in bone cancers, you can usually see hereditary and genetic predisposition, especially when you have, let's say, a 2-year-old who comes in with a really aggressive bone cancer or something called psychosocial. And those patients, you would think about something a mutation in the protein called P53. And then you would think about having a syndrome called default syndrome. And that's really important, because having this P53 mutation will actually predispose that child for other cancers down the road if we are so lucky to be treated the initial tumors. So in my experience, I've had a 28-year-old who had 8 different cancers throughout her entire life. And as you can see, it has just a huge total of 5 different.
So with a pediatric cancer patient and their risk of cancers when they become adult, is that related to genetics or the fact that they've been treated with certain types of radiation or chemotherapy agents? Why are they at increased risk?
I think it's really more genetics for children. So something going on with the genes that would cause it to be. It's not because, when you see a 3-year-old in a clinic, you can't really say, like an adult, oh, because you smoked too long, right? Therefore, you have cancer.